Welcome. Today we're diving into a less common, yet fascinating condition affecting the heart: coronary artery ectasia, or CAE. We'll explore what it is, what causes it, how it's diagnosed, and what can be done about it. Let's begin. So, what sparks CAE? In many cases, it's a consequence of atherosclerosis, the same culprit behind typical coronary artery disease, where plaque builds up in the arteries. However, it can also stem from congenital abnormalities, meaning a person is born with it. Other, less frequent causes include inflammatory conditions like Kawasaki disease or Takayasu arteritis, connective tissue disorders, or even be triggered by certain medications. But, in a considerable number of cases, the exact cause remains elusive. Now, let's understand what's happening inside the heart. CAE is characterized by an abnormal widening, or dilation of the coronary arteries. Think of your coronary arteries like pipes delivering crucial blood to the heart muscle. In CAE, these pipes become abnormally wide and irregular. This widening disrupts normal blood flow, creating areas where blood can pool and potentially clot. This impaired blood flow can then lead to ischemia, a shortage of oxygen to the heart muscle, and ultimately cause symptoms. The ectasia itself may also contribute to the formation of aneurysms, which are balloon-like bulges in the artery walls, further complicating blood flow. CAE isn't as prevalent as other forms of heart disease. Estimates vary, but it's believed to affect somewhere between 1 to 5% of individuals undergoing coronary angiography, a procedure used to visualize the coronary arteries. While it can occur at any age, it tends to be more common in older adults, particularly those with existing atherosclerosis or other risk factors for heart disease. The actual numbers may be higher, as many individuals with CAE may be asymptomatic and remain undiagnosed. The signs and symptoms of CAE can be quite variable. Some individuals may experience no symptoms at all. Others may experience chest pain or angina, similar to that caused by coronary artery disease. This pain may be triggered by exertion or stress. In more severe cases, CAE can lead to shortness of breath, fatigue, and even heart attack. The symptoms often overlap with those of typical coronary artery disease, making diagnosis challenging. Diagnosing CAE typically involves a combination of imaging techniques. Coronary angiography remains the gold standard. This invasive procedure involves inserting a catheter into a blood vessel and injecting dye to visualize the coronary arteries using X-rays. However, non-invasive methods like CT angiography or cardiac MRI can also be used to detect and assess CAE. These techniques provide detailed images of the heart and coronary arteries without the need for a catheter insertion. Your doctor will choose the most appropriate test based on your individual circumstances and medical history. While there isn't a universally accepted classification system, CAE is often categorized based on the extent and location of the ectasia. One classification, the Marcus classification, is used, classifying the disease from type 1 to type 4, depending on how many vessels are affected. Also, it can be classified based on whether or not it is associated with obstructive coronary artery disease. These classifications are helpful in guiding treatment decisions and predicting prognosis. The management of CAE focuses on alleviating symptoms, preventing complications, and addressing the underlying cause, if identified. Medications, such as antiplatelet agents like aspirin, are often prescribed to reduce the risk of blood clots. Statins may be used to lower cholesterol levels and stabilize atherosclerotic plaques. Beta blockers or calcium channel blockers can help manage angina. In some cases, invasive procedures like angioplasty and stenting or bypass surgery may be considered to improve blood flow to the heart. The specific treatment approach is tailored to the individual patient and the severity of their condition. Lifestyle modifications, such as adopting a heart-healthy diet, quitting smoking, and regular exercise, are also crucial. Unfortunately, there are no specific measures to definitively prevent CAE. However, adopting a healthy lifestyle can significantly reduce the risk of atherosclerosis, a major contributing factor. This includes maintaining a healthy weight, eating a balanced diet low in saturated and trans fats, cholesterol and sodium, engaging in regular physical activity, managing blood pressure and cholesterol levels, and avoiding smoking. Early detection and treatment of inflammatory conditions like Kawasaki disease may also help prevent CAE in some individuals. The prognosis for individuals with CAE can vary widely. Some individuals with mild CAE may have a relatively good prognosis, especially if they are asymptomatic. However, more severe CAE, particularly when associated with other forms of heart disease, can increase the risk of heart attack, stroke, and other cardiovascular complications. Recent research is focusing on identifying specific biomarkers that can predict the risk of adverse events in individuals with CAE. There's ongoing research in the area of optimal antiplatelet therapy, including the investigation of newer agents. Additionally, researchers are exploring the potential role of gene therapy and other novel approaches for treating SAE. The information we've covered is meant for general understanding only and should not replace the advice of a healthcare professional. If you have concerns about your heart health, please consult with your doctor.